Hello, welcome to part one of the respiratory system. In today's section, we are going to go through the anatomy of the respiratory system. And in part two, we will go through more of the physiology of the respiratory system. So what exactly is breathing? Breathing is also known as respiration, which is where we take in oxygen, we exchange oxygen in our blood with carbon dioxide, and we exhale carbon dioxide. We exhale other waste products as well. So that pulmonary ventilation or breathing, again, is every breath that you take, breathing in and breathing out. Every time this happens, we are exchanging gases in our lungs with the blood. We have external respiration, and this is gases between the alveoli, which are the smallest part in the lungs where gas exchange can actually take place, and the blood in the pulmonary capillaries. So this is what's happening. Internal respiration is where we exchange those gases. So there's a lot of different parts to the respiratory system. We have the upper respiratory system and the lower respiratory system. The upper respiratory system is from everything that's pretty much in your head, from that top of your neck up. The lower respiratory system is everything from the top of your neck down all the way into your lungs. We're going to go through all of the different parts of these today when we go through the anatomy. So there's functionally within our lungs, there's two different components that this respiratory system is divided into. We have this conducting zone. This is where air is traveling into the body, in through the nose or the mouth, and into those down, starting into the lungs. And then that respiratory zone, that is that area where the gas exchange will actually take place. So these two videos will go through an overview of the anatomy of the respiratory system and the different tissues within the respiratory system. So here is a drawing and a cadaver picture of lungs. You can see the heart in the cadaver picture, but in the lungs, we can start to see some of the different parts of the respiratory system specifically. In respiration, what is occurring? These looks like, I know I've heard people say they look like a bunch of grapes. These are different alveoli. This is where we have those simple squamous epithelial cells. They are the thinnest cells that we have in our body that allows for that exchange of carbon dioxide and oxygen between the blood. This is happening in this pulmonary circulation that was mentioned in the cardiovascular center or chapter with the heart. That right side of the heart sends that blood into pulmonary capillaries that's where the capillaries have those really thin walls where gas exchanges are occurring. Then that blood goes back to that heart before it leaves to go out into the rest of the body. So let's go through all of the different parts of the upper respiratory system. Your nose. Your nose is a part of this upper respiratory system. This is where air is going to enter the body every time you breathe in and leave the body every time you breathe out. So there's a lot of different things that are happening within your nose. There's a lot of different parts. We have the external nose. That's the part we can see. Every person has one, has a nose. The very top portion of your nose is bone, that nasal bone that you learned in Anatomy 1. The rest of it is cartilage. It's hyaline cartilage throughout. We even have septal cartilage that makes up part of that, especially on the outside part, that nasal septum. That portion that comes down the middle on the outside of your nose, that is that nasal septum. We have lateral nasal cartilage. This is below that nasal bone, that whole area that kind of flares out to the side on each of your noses. Starts to flare out because the alar cartilage is the part that actually forms each nostril. And then those nostrils are just those openings. Right inside of these nostrils, we have nasal vestibules. Your nose carries a lot of functions. For air to make it down in the lungs, first it has to be warmed. We have to warm it up. If you're ever outside in the middle of winter when it's really cold and you take a breath in, it's very cold. You can feel it down into your lungs if you're breathing through your mouth. Your nose helps to warm that air. Your mouth can warm the air a little bit as it comes in, but not as well as your nose does. It adds moisture to it. It humidifies the air. We also filter the air, so we're not breathing in all these different particles. This is what's happening when the air first enters your nose. As you learned in Anatomy 1, your nose allows you to smell. It has that olfactory nerve that comes in at the roof of your nasal cavity and allows you to be able to detect different smells. It even helps to modify different speech vibrations. So as your voice vibrates, as you talk, your voice is creating this kind of vibration, and it turns your nose into kind of this resonating chamber. This all kind of works to create what voice you actually have. A rhinoplasty. This actually deals with your nose. It's having a nose job. It's where that whole external portion of your nose gets altered. People do it for cosmetic reasons because they want their nose to look a certain way. But there's other reasons to get a nose job done. They have that rhinoplasty. A fractured nose. Something happens and your nose gets fractured. We also can have a deviated septum. That nasal septum is off to the side. With that nasal septum being off to the side, it can actually cause problems with breathing. So sometimes they'll do a rhinoplasty, that nose job, to fix that deviated septum. So inside of this nose is the nasal cavity. This nasal cavity, we've got muscle in there, so it would be some smooth muscle, because we can't control the size of our nasal cavity. We also have mucous membranes in there. Your nose, the inside of your nose is a moist area. So these mucous membranes are creating this mucus to help filter out different particles that you could be breathing in. So as I mentioned, that septum is going to give us that right and that left side. The front part is that hyaline cartilage. The posterior part, the inside of your nose, inside of the skull, the rest of your nasal septum is created by the vomer and those perpendicular plate that comes down off the ethmoid bone. We even have the maxilla that provides that lateral portion and the palatine bone that provides that posterior part. The cannae or internal nares. This is an opening in the back of that nasal cavity that allows that air to go into that pharynx, the back of your nose, throat. That whole area is known as the pharynx. We have different ducts. We have ducts from these different nasal sinuses that are going to empty into that nasal cavity. That nasolacrimal duct, that also empties out your tears or any of that lacrimal fluid that gets secreted from your eyes, drains that down into your nasal cavity. We have several different bones that have sinuses within them. We have the frontal bone. So you have sinuses in that frontal bone above your eyes. The sphenoid bone. That sphenoid bone, kind of that bat-shaped bone that sits in the middle of our skull. That ethmoid bone even has those ethmoid air cells. Those are sinuses. And then that maxilla. Underneath your eyes, lateral to your nose on either side, there's sinuses in there. That maxilla, where that bone sits. And again, it's a resonating chamber. It's going to give your voice its specific tone. So here we can see some of these different portions of our nose. As I mentioned, that nasal bone, that's at the very top part of your nose. We have this whole cartilaginous framework that makes up the rest of our nose. We have that nasal septal cartilage, that lateral nasal cartilage. We have the alar cartilages that make up most of that opening to your nose. So let's look at the inside some more. That nasal vestibule that sits right inside of your nose. We've got a lot of mucous membranes in there. We have the olfactory epithelium even that sits at the top of the nose. That's where we pick up different smells. Here we can see some of these sinuses. See this frontal sinus up at the top? Here we can see this sphenoidal sinus through here, part of that sphenoidal bone. Inside of our nose, we also have what are known as nasal concha. You may remember from Anatomy 1 that inferior nasal concha. Well, there's technically 3 nasal concha. We have a superior, a middle, and an inferior nasal concha. These are kind of rounded portions within the bone. They kind of come out and round around, curl around. These kind of work as turbines. Air comes in that circulates through this area to help moisten and warm that air before it starts to head towards this choana. So this is all happening in our nose. Here we can see a nice drawing. You can see out these different, the superior nasal concha, middle nasal concha, inferior nasal concha. Those are the actual portions of the bone that stick out. You can see them through this kind of frontal or coronal plane. You can actually kind of see this nasal concha here that curls up and around, all of these different ones, and then this, even the superior one up here. These are all different areas that air's going to circulate through to help warm the air that you breathe. So on the outside of the nose, we have this surface anatomy to your nose. The root of your nose is actually up towards the top of your eyes. That apex, just like the heart, the apex of the heart is at the bottom, the apex of your nose is at the bottom. That bridge is that nasal bone. And then the nostrils are those openings. So our pharynx, the next area. Our pharynx is the opening between your nose, the back of your throat, and down into that esophagus or trachea. It's named for what region it's located in, like the nasopharynx, that's at the back of the nose. Oropharynx, that's at the back of the mouth. Oral. Laryngopharynx, that goes down into that where we have our voice box, where we separate our trachea from our esophagus. This is all different areas of this pharynx, and both air and food begin in the pharynx, and then they will get separated into going down that esophagus for the digestive system or going down the trachea for the respiratory system. Just like the sinuses, this pharynx works as a resonating chamber for your voice. We have different tonsils. We mentioned our tonsils in the lymphatic system. The tonsils are usually found in this pharynx. So the different areas within this respiratory system, the upper respiratory system, I should say. I had mentioned it in the pictures. This goes through the words for a lot of this. We have that respiratory epithelium. There's a lot of goblet cells found within this ciliated pseudostratified columnar epithelium. These goblet cells are producing that mucus. That ciliated pseudostratified columnar epithelium is in there to help move that mucus. That nasal vestibule, again, is that opening just inside of that nose. So when you first breathe in, air is going through that nasal vestibule. There's a lot of hairs that are in there. Those hairs work to filter out large particles, prevents us from inhaling stuff we shouldn't. We then have that superior nasal concha, middle nasal concha, and inferior nasal concha that works to air circulates through those to warm and moisten or humidify that air. The area that's underneath of those nasal concha are meatuses. So we have the superior meatus that's right underneath that superior nasal concha, that middle nasal meatus, underneath that middle nasal concha, and that inferior meatus underneath that middle nasal concha. So, as I just said, it gets swirled around those nasal concha. What helps to warm the air is these blood capillaries that are in this nasal mucous membrane that sits inside these nasal concha. This will cause particles to get filtered out, that warmth of that blood to warm that air, and then that cilia is going to move any of those dust particles back towards the back of your nasopharynx. They'll go down to that oropharynx and allow you to swallow it down. And those olfactory nerves, those sensory neurons, are what pick up those different smells. It's considered that olfactory epithelium. There's cilia in this olfactory epithelium because we have epithelial cells in there. But there's no goblet cells. They're not secreting out the mucus like there is in the rest of the mucous membranes of the nasal cavity. So this pharynx, it's about 5 inches long between the nasopharynx all the way down to the laryngopharynx at the bottom. And it, again, is labeled for what area it associates with. We have that nasopharynx at the back of the nose, the oropharynx in the back of the mouth, and the laryngopharynx where that larynx is found. We have skeletal muscle in most of our pharynx because that skeletal muscle will allow us to swallow. We're going to look mostly at the nasopharynx when we're looking at the upper respiratory system because, again, this is the respiratory system. When we get to the digestive system, we will talk more about the oropharynx. We'll also talk about the laryngopharynx today because breathing in and out air plays a role in your vocal cords working. The posterior portion of your mouth, that soft palate, where that uvula, the little thing that hangs down in the back of your throat, where that hangs out, that actually can close off that nasopharynx when you swallow to prevent any liquids that you may be swallowing to go up into your nose. So the nasopharynx. This nasopharynx has a bunch of different openings in it. Your auditory tubes, or those eustachian tubes from the inner or the middle ear, will open into that nasopharynx. We have our pharyngeal tonsils that actually sit in the nasal pharynx, that back nasal pharynx. So when you're breathing stuff in, again, that's our immune system working. That immune system is working in there to remove any kind of microbes or pathogens that we may have just inhaled in. It's still lined with that ciliated pseudostratified columnar epithelium because that cilia is going to help move any mucus towards the back of the throat. your auditory tubes, they usually remain closed, but every time you swallow, they open up slightly. And it's working to equalize air pressure in that middle ear, that tympanic cavity, and the atmosphere around it. If you've ever flown in a plane before and you feel the need to pop your ears, or if you're going in an elevator really high and you feel the need to pop your ears, this is what we're doing, is we're opening up that auditory tube to exchange air to equalize the pressure in that middle ear with the outside. This oropharynx, it's again in the back of the throat, so it's from that soft palate to where this epiglottis sits. The epiglottis is the thing that opens and closes in the back of the throat. It closes to cover up the trachea anytime you're swallowing something. So water or any kind of liquid or food does not go down that trachea. The oropharynx only has one opening, which is your mouth. But it does also respiratory functions just like it has digestive functions, because we can breathe in and out through our mouth just like we do with our nose. The oropharynx is instead lined with non-keratinized stratified squamous epithelium, because anytime you're moving food around in your mouth, chewing it, breaking it down, what we are doing is these foods hit the different areas in your mouth, it puts wear and tear on those cells. So stratified squamous epithelium is designed for that wear and tear that we put on those different cells. We have two tonsils in that oropharynx. We have the palatine tonsils and the lingual tonsils. Again, your immune system working on anything that goes in through your mouth, trying to prevent you from getting sick. And then that laryngopharynx, the last part of the pharynx here. It starts at that hyoid bone. So right at the base, the bottom of your, or the top of your neck, I should say. And it goes all the way down into the esophagus and that larynx, or that front part of that trachea in the front. Again, since it's both respiratory and digestive, we have non-keratinized stratified squamous epithelium in this specific area. So let's look at the larynx. What is the larynx? Well, the larynx is your voice box. And it's a very small area where this trachea and the laryngopharynx kind of connects. It's kind of found between C4 and C6 vertebrae. So kind of towards the bottom of your neck. And what is in that area, we have our thyroid, we have our epiglottis. In that area, we also have that cricoid cartilage in that area. We have different cartilages. We have the arytenoid, cartilage, the cuneiform cartilage, and the corniculate cartilages found in that area. In the arytenoid cartilages specifically are what are going to change that tension on your vocal cords to allow different volumes, to allow different sounds. We have extrinsic and intrinsic muscles within this larynx that are, again, going to help your voice. Change that intrinsic and extrinsic, or change the tension and position of your vocal cords for different sounds, different volumes. We have that laryngeal cavity, goes from the beginning of the larynx to that bottom of that cricoid cartilage. We have this laryngeal cavity, and it's actually right above these vocal folds that are also known as the laryngeal vestibule. We have the infraglottic cavity, which is just below the vocal cords. So let's kind of look at everything that is happening in here. So this larynx is going from, technically from that hyoid bone down to where this trachea kind of starts. So let's look at everything here. This epiglottis is this, portion, this thing right here that it moves up and down to cover up that larynx and that trachea and open it back up. Here's that thyroid cartilage. If you look from the inside, you see that arytenoid cartilage. There's the cricoid or cricothyroid ligament. Here's the cricoid cartilage, the front and the back portion of it. You even see that thyroid gland. There's a lot happening in here. We slice it down the middle, we can start to see what is happening inside. So again, we start with that hyoid bone at the top. We have that cuneiform cartilage. We have that corniculate cartilage, that arytenoid cartilage. The top of these two portions is the vestibular fold. The next one down is the vocal fold. So this is that vestibular fold. This one is that vocal fold. We even have that cricoid cartilage found throughout here. So this thyroid cartilage, it's technically two different pieces that fuse together during growth. And it's in the front of the larynx. Both men and or males and females have it. Males are slightly larger. That thyroid cartilage is what kind of gives that Adam's apple appeal. Look, that's what I was looking for. So that Adam's apple in men, that is actually their thyroid cartilage. We also have this epiglottic cartilage, which is that epiglottis. That is that piece that moves up and down. So during swallowing, the pharynx and the larynx both rise up. When that pharynx, the elevation of it, it'll widen to allow food to go in. Elevation of the larynx specifically causes that epiglottis to fold down and close off that esophagus. When the pharynx widens and rises, that's what allows us to swallow food. The glottis is what has those vocal folds in it. And then the space between the vocal folds and the vestibular folds through there is that rima glottis. In that larynx, we have that epiglottic cartilage. And that's what closes the larynx off to keep any food or liquid from going down into that larynx and into that trachea. Sometimes some particles can get down in there. Dust, smoke. When food does go down there, it does happen, or even liquids. This is what causes this cough reflex to happen, to try to expel it back out of that larynx specifically. That cricoid cartilage. These are rings of hyaline cartilage at the bottom walls of that larynx. Its attachment sites for the cricotracheal ligament and the cricothyroid ligament. Those are retinoid cartilage that we looked at in the picture before. These are kind of at the posterior, superior part of that cricoid cartilage, and they actually form synovial joints with that cricoid cartilage. We have that corniculate cartilage, kind of look like little horns. And these help these vocal folds and part of that epiglottis as well. So all the different parts that help you in your voice to actually produce a sound. Those vestibular folds or the top folds, they do not function in voice production. If you hold your breath, these vestibular folds are helping to hold your breath. So they kind of close off to help put pressure against that thoracic cavity. The vocal folds are the inferior part. They are what produce your voice. They're elastic ligaments because they need to stretch. So when muscles contract, they're going to help these move this cartilage in that larynx, and that pulls on the elastic ligaments of your vocal folds tight. And when they're pulled tight, it stretches those vocal folds into the airways. So contracting and relaxing of the muscles in the larynx, specifically, it changes the tension on those vocal folds. Then as air passes through those vocal folds, it's going to vibrate those folds. And this is what produces sound. It's different waves as this air moves through the larynx and causes those vocal folds to vibrate. We have the rima vestibuli. That's just the space between the vestibular folds. And then we have the laryngeal ventricle, kind of an expansion to the middle. And it's right below the vestibular folds and right above the vocal folds. So here we can see we've got this muscle through here, this cricoarytenoid muscle. You can see this vocal ligament. When this muscle contracts, it pulls these vocal ligaments, one picture down to the next here, together. When those muscles relax, those vocal ligaments move towards the outside, which is what's happening in the top picture. Same thing in the other picture, but this time we're looking at everything that is in that area. So we see the vocal folds. We see those vestibular folds to the outside. That rima glottis is actually between the two. And they can, when these muscles contract, it can change how wide those vocal folds actually are, and it changes the tension. When you change the tension of those vocal folds, you are changing the pitch of your sound. Laryngitis. Sure, most people have had some form of laryngitis in their lifetime. That got itis, so it's an inflammation of that larynx. And it's a respiratory infection usually. Sometimes irritants like cigarette smoke can cause laryngitis, but because of this inflammation and swelling in the area, your voice goes hoarse. You can even lose your voice because that swelling interferes with those vocal folds from actually, or those, vocal cords from actually moving. So that muscle, when it can't contract to move those vocal folds to vibrate to create your voice. Cancer. Cancer in the larynx is almost exclusively found in people who smoke. So they have a constant hoarseness. They may have that pain with swallowing. The pain can even radiate to the ear just because of nerve pathways that travel on the same axons. That's how pain kind of travels to different places. They may have to have part of that larynx removed, or they would do some sort of radiation therapy to try to get rid of those cancerous cells that are growing in that area. Onto the trachea. So we've just passed through that larynx. The trachea is also known as that windpipe. It's about 5 inches long, about an inch wide. It is in front of the esophagus. And it will travel down to just at the top of the 5th thoracic vertebrae. At that point, it is going to divide into a left and a right. So there's different layers to the trachea, just like there's different layers to everything else. We have that respiratory mucosa, which is that ciliated pseudostratified columnar epithelium. That is attached in that trachea by the lamina propria of elastic and reticular fibers. That helps hold that epithelium down. Underneath that, we have the submucosa, which is connective tissue. Underneath that, we have hyaline cartilage rings. They are technically these like C-shaped rings that wrap around the trachea, and it works to hold the trachea open. We have stacks of them that travel down the entire esophagus, and its only job is to hold open the trachea. It's C-shaped because behind, a different color, the trachea, we have the esophagus that lies pretty flat. That's not a good drawing. Let's try this again. It lays pretty flat back here. And when it opens, it actually pushes onto that trachea. You're not able to breathe in and swallow at the same time. It's one or the other. So this esophagus will open up and it kind of pushes into this area in the trachea as things travel down. Then we have this adventitial layer, the outside layer, again, areolar connective tissue, and it helps that trachea attach to all of the tissues that sit around it. So here we can see this cartilage C ring. It's a really nice circular shape. That's that tracheal cartilage. Here you can see that esophagus that sits behind it. And then we have technically this trachealis muscle that sits in this open membrane but it allows that esophagus to expand kind of into that area every time that we swallow. Here's, and this nice electron micrograph, we see that ciliated pseudostratified columnar epithelium. We just see the cilia, but we can see lots and lots of goblet cells sitting around it because that goblet cells produce that mucus again. It is collecting anything that was not caught in the nasal cavity or through the oral cavity that got down into that trachea while we were breathing. It produces mucus to try to collect any particles that may have gotten past the nose or the mouth to prevent that going down into the lungs. Tracheostomy. It is a tracheotomy too, but it's usually done under general anesthetic. It's where an incision is made into the neck area, and they're making an incision into the trachea. They put an endotracheal tube, and it provides an airway when something has happened to the nose or the mouth, so they can't get air in that way. These people usually need a mechanical ventilator or a breathing machine. If they have vocal cord paralysis, throat cancer, neck or mouth injuries, burns in your airway, something obstructing that airway, foreign body obstruction, that would cause this tracheostomy or tracheotomy to be done. We have an endotracheal tube or intubation. This is to maintain that open airway into that trachea. They do it under anesthesia. They don't put these in while you're awake. They put these in for surgery when you're asleep. So this tube is sent through the mouth, sometimes the nose, and into that trachea, through that pharynx, through that larynx, down into that trachea. A mechanical ventilator. This is a machine that does the breathing for you. It's a form of life support, and it provides oxygen to your lungs, so your lungs can exchange that oxygen with your blood. It's going to get rid of that carbon dioxide and all of those waste products that your cells are producing. So after the trachea, that trachea comes down, it splits to that right and that left, what are known as bronchi. We have the right main bronchi, the left main or bronchus, the left main bronchus. So we have, these are the main bronchus. At this point right here, that where the split happens, that is known as the carina. This is actually the most sensitive area of the entire larynx. Something hits this carina, it's going to trigger you to cough. Once these main bronchus actually enters into the lungs, they're going to start to divide further, and divide further. So these main bronchus are going to divide into what are known as lobar or secondary bronchi. Each lung has lobes. The right lung has 3 lobes, the left lung has 2 lobes. And the reason for this is because of the heart. That heart sits more on the left side, so it takes up more space, so that left lung is a little bit smaller than the right. Those lobar or secondary bronchi turn into segmental or tertiary bronchi. So they're branching off even further. There's 13 segmental bronchi just in the right lung. There's 8 in the left lung. Those segmental bronchi are dividing even further into bronchioles. It's like a big tree. Those bronchioles divide even further into terminal bronchioles. These terminal bronchioles have exocrine bronchiolar or Clara cells. And they're there to, again, help protect from any kind of toxins or carcinogens. They produce this surfactant that we will talk about shortly. And they also function as these stem cells. This is the end of the conducting zone, is these terminal bronchioles. These conducting zone is where air is just traveling through. It is not where exchanging of gases occurs. It's just where air is traveling through. This is all part of this bronchial tree. Do we have a picture of this here? Yeah. Here's this picture. We go from the trachea. We have this left main bronchus, this right main bronchus. Then we go to those lobar. They're going to split. So here's the main bronchus. They split. We see this right superior lobar bronchus, right middle lobar through here, and then that right inferior bronchus here. Those are going to split into segmental. Those segmental here split even further into bronchial. And then they're going to go to terminal bronchial. That is that whole tree. Beyond that, they go to respiratory bronchioles and alveolar ducts. At this point, they can start exchanging gases. From the trachea all the way down to the alveolar ducts, there is 23 generations of branching. So they branch technically a total of 23 times by the time they get down to those alveolar ducts. So every time it changes its name, it branches even further, a whole lot more. The main bronchial, the main bronchi, lobar bronchi, and segmental bronchi are ciliated pseudostratified columnar epithelium. They will go into ciliated simple columnar epithelium with some goblet cells. They'll start going to ciliated simple cuboidal epithelium. They turn into simple cuboidal epithelium. So the cells just get smaller and smaller and smaller. They start losing their goblet cells. Where there's no cilia, we have macrophages. They will remove any kind of particles. They will remove any kind of microbes that may have gotten that far. Those cartilage rings, they start to become smaller and smaller until they finally completely disappear. We start to get more smooth muscle instead of cartilage rings. And smooth muscle is going to go around those entire bronchioles, terminal bronchioles. We have smooth muscle in there. So where there's no cartilage, if that smooth muscle were to spasm, it could completely close off those airways. And that is what is happening during an asthma attack specifically. That smooth muscle is spasming and completely closing off that area. Exercise. Exercise stimulates that sympathetic nervous system. And when that sympathetic nervous system gets stimulated, it stimulates epinephrine and norepinephrine to be secreted out. These hormones will relax that smooth muscle, which makes the airways larger. So it makes it easier to breathe when you're exercising. Air reaches down to those alveoli faster. That parasympathetic, and then we have mediators of allergic reactions like histamine, constrict that smooth muscle, which either makes them smaller or can even completely close them off in an asthma attack to all of those bronchioles with that smooth muscle. So here, the right lung, that left lung, you can see all of the different parts and everything that is happening. We went through and showed all of this different branching that is taking place. So this goes through and shows the pathway. We have the trachea to the main bronchi, to the lobar bronchi, to the segmental bronchi, to the bronchioles, to the terminal bronchioles, as everything continues to branch and just get smaller and smaller and smaller. The terminal bronchioles, again, are the end of that conducting zone. So that is just the end of where air is traveling through. There's no gas exchange happening at this point. So this is a nice chart that shows some of this branching that is taking place. The respiratory zone is in these respiratory bronchioles, these alveolar ducts, and these alveolar sacs. This is where we can exchange air or exchange oxygen and carbon dioxide with our blood. Air is now, once air travels into this area, gas exchange can actually happen. Our lungs, they're paired. We have a right and we have a left. The right is slightly larger than the left. So our lungs in general. That heart is going to be in the middle of those, and those two lungs. Purpose for two lungs: if something happens, if damage happens to one of the lungs, we still at least have one lung that can still work. So we can still breathe. May not be as efficient, but we can still breathe. Just like the heart has that pericardial cavity, that membrane that fits around it, the lungs have the pleural membrane. Pleural is for lungs. And that parietal layer is what faces out away from the lungs. That visceral sits right on top of the lungs. And that cavity, the space between the two, is filled with pleural fluid. Like we have pericardial fluid, we have pleural fluid. This membrane is going to reduce the friction, allows for the lungs to expand and recoil when we breathe in versus breathing out. That fluid, it can cause the membranes to actually stick to each other and create tension. Pleurisy. What if one of those, that pleural membrane, gets inflamed? So in those early stages, pleurisy is pretty painful. And it's because of the friction between those two layers. Pleural effusion, there's too much fluid that accumulates in that pleural space. Makes it more difficult to breathe. So this pleural membrane is going to protect our lungs. A pneumothorax. A pneumothorax is when that pleural cavity, more often it fills with air, but it can also fill with pus. It can happen because of surgery to the chest, stabbing, or a gunshot wound to that chest. And it can even cause that lung to collapse, atelectasis. So treatment is to get rid of that air from that pleural cavity. As soon as the air is removed from that pleural cavity, that lung is able to reinflate. Some pneumothoraxes can actually heal and fix on their own. But sometimes we need to put a chest tube to assist to help that air actually leave that pleural cavity so that lung can reinflate back up. So our lungs. The base is at the bottom this time. So the base of your lungs sits on the diaphragm. The apex is the top, that superior portion. We have a costal surface, and that is what lines up against those lungs, or the lungs against those ribs. There we go. The mediastinal surface, so this is the middle portion, they have a hilum. The hilum, we haven't seen the hilum yet in a picture, but that is where those primary bronchi enter the lungs. We have those pulmonary vessels, those pulmonary arteries and veins that enter and leave the lungs. Lymphatic vessels even enter and leave the lungs there. Nerves enter and leave the lungs. They're all held together at the root, which is made of the pleura and that connective tissue. The left lung, because the heart sits there, has a cardiac notch. That drawing doesn't do that justice. That cardiac notch right here, this is for that heart to fit in. It lets that heart have enough space that is needed. So the left lung is about 10% smaller. It is smaller, but not by much. That right lung is actually shorter because of the liver that sits just underneath that diaphragm on that right side. So that makes up for some of that space. So here we can see that left lung versus that right lung. That base of the lung is at the bottom. That apex is at the top. Here's the interesting part that most people don't know. Here's your clavicle. The apex of the lung sits above the clavicle. So you feel where your clavicle is. That top portion of your lung, that apex, sits above that. Most people don't know that. So we have different lobes and we have different fissures. Fissures are going to divide the lungs into those different lobes. Both lungs have an oblique fissure, but that right lung also has a horizontal fissure because it has 3 lobes. So that left lung only has a superior and an inferior lobe. The right lung has a superior, inferior, and a middle lobe. Each lung, or each lobe, receives a lobar bronchus. So that right main bronchus is going to give us a middle, an inferior, and a superior lobar bronchi, while that left is going to give us a superior and an inferior lobar bronchi. That lobar bronchi is going to split off to those segmental bronchi, 10. And that goes to that bronchopulmonary segment. Each bronchopulmonary segment has lots of different compartments that are known as lobules. The terminal bronchioles, they're going to keep branching out to these respiratory bronchioles. And these respiratory bronchioles are going to go to these alveolar ducts. So here's our lungs. That apex at the top, the base at the bottom. On this left lung, we have that superior lobe. We have that oblique fissure with that inferior lobe and that cardiac notch specifically. Our right lung, we have that apex, we have that base, we have an inferior lung, oblique fissure, middle lobe, horizontal fissure. Again, they are named for their position with that superior lobe. The hilum. The hilum is this entire opening. We have our bronchi or primary bronchus that enters the lungs here. We have our pulmonary arteries and our pulmonary veins that go through here. We even have lymphatic vessels that go through here. So this is where everything enters and leaves the lungs. Okay, the alveolar saccule or alveolar sacs. This is at the end of the alveolar duct, and it is this as a dilation. It looks like that bunch of grapes on the stem. That's where these alveolar sacs are found. And this is where we contain pulmonary alveoli, where gas exchange is going to happen. There is about 100 alveolar sacs at the end of each alveolar duct. And each alveolar sac has 20 to 30 alveoli. We have different cells that line these different alveoli. We have pneumocyte type 1, which is a simple squamous epithelial cell. This is where our gas exchange happens at that pneumocyte type 1. They do secrete pulmonary alveolar fluid, and that's to keep those cells moist. They also secrete surfactant. Surfactant helps this alveolar fluid. What it does is it prevents those alveoli from collapsing. Without the surfactant, they would completely collapse down every time they empty out with air. So as it's called, they maintain their patency when these pneumocyte type 1 cells secrete this surfactant out. Pneumocyte type 2 or septal cells, we don't have as many of those. They're found between these pneumocyte type 1 cells. And then we also have alveolar macrophages, because again, they're phagocytic. Any fine dust that has made it all the way down to these pulmonary alveoli, these alveolar macrophages come in and ingest. They're removing any debris, anything that has made it down this far. So we go from those respiratory bronchioles to that alveolar duct, to the alveolar sacs, to the alveoli. This is where all this gas exchange is occurring. So you can see through these pictures, we have this terminal bronchiole, which gives way to respiratory bronchioles, which gives way to pulmonary alveoli, which are giving way to alveolar ducts, which gives way to these pulmonary alveoli, which has these alveolar saccules. Looks like a bunch of grapes. So again, it just keeps getting smaller and smaller and smaller till we get to these pulmonary alveoli where most gas exchange occurs. Here we can see this respiratory bronchiole that goes to this alveolar duct Then we can even see all these different pulmonary alveoli, even these alveolar saccules where all this gas exchange is occurring. These are mostly simple squamous epithelial cells because those are the easiest cells for particles to move through or gas to move between. So most exchange of oxygen and carbon dioxide takes place in these pulmonary alveoli and between the capillary walls. These are known as the respiratory membrane. These respiratory membrane are going to have 4 layers technically. We have that alveolar wall, which is those pneumocyte type 1 and type 2 cells with those alveolar macrophages. We have an epithelial basement membrane. Then we have that capillary basement membrane, that capillary endothelium. They're all very thin. And that's what allows this gas exchange to happen. So as we can see, here's some of these pneumocyte type 1 cells through here. Here's a pneumocyte type 2 cell. You see this alveolar macrophage in green there to help clean out any kind of fine particles that have made it this far. You can see this capillary endothelium, that basement membrane of that capillary, the epithelial basement membrane of the alveolar wall with that type 1 pneumocyte. This is all that air has to pass through, or that oxygen and that carbon dioxide has to pass through to exchange. So these different pneumocyte cells. In this microscope slide, you can see some of these alveolar macrophages, these type 1 alveolar cells. The type 2 pneumocyte, they tend to stain a little bit darker. They're a little bit thicker. So blood to supply to the lungs. The lungs are going to receive blood from the pulmonary arteries and then bronchial arteries from that systemic circulation. So that deoxygenated blood is going to go through that pulmonary trunk of the heart that are going to go to those pulmonary arteries. Once the blood has received oxygen, gotten rid of carbon dioxide, the blood goes back to the heart through one of 4 different pulmonary veins. They drain into that left atrium. These pulmonary vessels, they have some different features. They usually have low oxygen levels at hypoxia. When they have low level oxygen levels and within those vessels will constrict. Other body tissues dilate when there's low oxygen. In the lungs, they constrict. Ventilation, perfusion, coupling. So constriction of these vessels in response to low oxygen levels causes blood to go from poorly ventilated areas to well ventilated areas to allow this gas exchange, this blood to pick up as much oxygen as it can. These bronchial arteries that go from the aorta deliver oxygenated blood to the tissues of the lungs. So that smooth muscle, those of the bronchi and bronchioles, they need blood. So bronchial arteries, just like the heart has coronary arteries that feeds the tissues of the walls, the lungs need the same thing. Even though that we're exchanging gases in the lungs, we'd still need nutrients to go to the walls of these different bronchi to allow this whole process to happen. So some of this blood drains into bronchial veins, which are branches of the zygos system. and returns to the heart. So, coryza. That is another name for the common cold or that rhinovirus. They've actually found when you're under a lot of emotional stress, the higher the stress, the greater the frequency and durations of colds. So when you're under a lot of stress, you're more sick for a longer period of time. Seasonal influenza, or that seasonal flu that's caused by the influenza virus. The seasonal flu is usually either influenza A or influenza B virus. It's a respiratory disease. The seasonal flu is not a digestive disorder or virus. It affects the respiratory system only. They do have overlapping signs and symptoms sometimes, so sometimes it's hard to tell the difference between the flu and the cold. The onset of the flu is usually pretty abrupt. It all of a sudden kind of comes out of nowhere. You have chills, a high fever, over 101 for several days. The problem with the flu is it can cause pneumonia if it travels down into those lungs. It can worsen heart disease. It can cause bronchial asthma. It can travel into the brain and cause neurological problems. It can cause respiratory failure. The cold is more gradual. You can kind of feel it coming on day by day. You usually can have sinusitis, so inflammation and swelling into the sinuses, ear infections, laryngitis, and bronchitis. These are all more associated with a cold. So these charts go through the different parts of the upper respiratory system into the lower respiratory system. And this is everything for part 1 of the respiratory system. I will see you again in part 2. Thank you. Bye.